Welcome to my very first video on this channel. We are going to cover complete high-yield embryology from one cell to a fully formed human. Let's watch it happen. Every human life starts in the same place, the ampulla of the uterine tube. That's the white part of the fallopian tube, about a third of the way in. This is where sperm meets egg. But the sperm cannot fertilize the egg right away. It has to go through changes first. Capacitation takes about 7 hours. It strips glycoproteins off the sperm's surface, priming it to react. Then comes the acrosome reaction. The sperm releases hyaluronidase and proteases, digesting a path through the corona radiata and the zona pellucida. Once one sperm gets in, your patient's egg cannot let a second one in. That would be lethal to the embryo. The cortical reaction hardens the zona pellucida within seconds, physically blocking polyspermy. The result is that the secondary oocyte finishes meiosis to the two pronuclei fuse and you have a diploid zygote. That's day zero of a new human. After fertilization, the zygote doesn't grow bigger, it just divides. These rapid mitotic divisions produce smaller and smaller cells called blastomeres, all still trapped inside the zona pellucida. By day 3 to 4, you have a solid ball of about 32 cells. That's the morula. By day 5, fluid starts collecting inside and you get a blastocyst. The inner cell mass, the embryoblast, is going to become the actual embryo. The outer cell mass, the trophoblast, is going to become the placenta. That distinction is exam gold. Before implantation can happen, the zona pellucida has to degenerate. We call this hatching. Implantation happens in the posterior uterine wall during the secretory or progestational phase of the cycle, with the embryonic pole going in first. As the trophoblast burrows into the uterine wall, it splits into two different layers. The cytotrophoblast is the inner layer. It's still mitotically active, still dividing. The syncytiotrophoblast is the outer layer. It's multinucleated, it's invasive, and here is the key point. It does not divide. This outer layer is what makes SCG, human chorionic gonadotropin. And SCG's job is to rescue the corpus luteum so it keeps making progesterone, which keeps the pregnancy going. This is exactly why a urine pregnancy test works. It's picking up SCG in your patient's urine days before her missed period. By week 2, the embryoblast rearranges into two flat layers. That's why we call this the bilaminar disc. The epiblast is the columnar layer on top. Remember this one, because it's going to give rise to all three germ layers during gastrulation, and it also forms the amniotic cavity. Underneath sits the hypoblast, cuboidal cells that form the primary yolk sac. Where the epiblast and hypoblast fuse at one end, you get the precaudal plate. This marks the future head end and future mouth. The extra embryonic mesoderm, which comes off the epiblast, splits into a somatic layer lining the trophoblast and amnion, and a visceral layer covering the yolk sac. That space between them becomes the chorionic cavity. Here is a high yield point. The very first blood cells in your patient's body don't come from bone marrow. They come from mesoderm around yolk sac, weeks 3 through 6. Before the liver, spleen, thymus, and finally bone marrow take over. Week 3 is when your embryo goes from 2 layers to 3, and this process is called gastrulation. It all starts with the primitive streak forming on the epiblast. Think of it as a groove running down the midline. Epiblast cells detach, dive down through that streak. We call this ingression, and stream out to form new layers underneath. What's left on the surface plus what forms the nervous system is ectoderm. That surface ectoderm, neuroectoderm, and neural crest. The middle layer, mesoderm, splits into paraxial, intermediate, and lateral plate. You will see these become muscle, kidney, and body cavity linings later. And endoderm becomes your gut tube and its associated organs. By the end of week 3, all three germ layers are in place. Everything in the human body traces back to one of these three. One structure from mesoderm deserves its own spotlight, and it's the notochord. It comes from the notochordal process, and its job is to induce the neural plate to form. Later in life, the notochord's remnant is the nucleus pulposus, the gel center of your intervertebral disc. Now, here is a classic example. If remnants of the primitive streak fail to regress properly, you can get a sacrococcygeal teratoma because it's come from primitive streak cells, which can become any germ layer. This tumor contains tissue from all three layers, and it's actually the most common congenital tumor found in the newborns. Now let's watch the nervous system get built. Around day 18, the notochord signals the ectoderm move it to thicken into the neural plate. That plates fold upward into the neural folds, and those folds fuse together to form the neural tube. Picture a zipper. It starts closing in the future neck region and moves in both directions at once, cranially and caudally. The rostral or cranial opening is the neuropore, which seals up around day 25. The caudal neuropore follows 2 to 3 days later, around day 27 to 28. This timing matters clinically. If that rostral neuropore fails to close, your patient's baby is born with anencephaly, and if the caudal neuropore fails, you get the spina bifida spectrum, from occulta to meningocele to meningomyelocele. The neural tube is not uniform. Different signals tell different parts what to become. Sonic hedgehog from the notochord and floor plate ventralizes the tube. That's where your motor neurons end up. BMP4 coming from the roof plate and overlying ectoderm dorsalizes the tube. That's where sensory neurons form. By week 4, you have three primary brain vesicles, and by week 5, those split into five secondary vesicles, the building blocks of your entire brain. Now, this is one of the highest ill facts in embryology. Neural crest cells peels off the tips of the neural folds and migrate all over the body. They become your peripheral ganglia, Schwann cells, melanocytes, the adrenal medulla, even part of your heart's outflow tract. But be careful. The brain's own support cells, astrocytes, and oligodendrocytes come from neuroepithelium itself, not neural crest. And microglia are the odd ones entirely. They are mesoderm derived, originating from yolk sac macrophages. Folate deficiency, valproic acid, and carbamazepine all raise neural tube defect risk. Periconceptional folic acid is protective. So far, your embryo has been flat, and it's like a disc. In week 4, it folds into a cylinder, and the driving force is the neural tube growing faster than everything around it. Folding happens in two directions. First, cephalocaudal, in which a head folds form at the top and the tail fold at the bottom. The head fold pulls the septum transversum and the buccopharyngeal membrane, the heart tube, and the pericardial cavity into what will be the thorax. The tail fold brings the cloacal membrane, the allantois, and the connecting stalk around to the belly. Second lateral folding the two edges of the disc curl toward each other ventrally. This pulls part of the yolk sac into inside the embryo, forming the primitive gut tube, foregut, midgut, and hindgut. The midgut stays briefly tethered to the yolk sac by the vitelline duct, and the connecting stalk becomes what you will know as the umbilical cord. Clinically, if the vitelline duct does not appear, your patient ends up with a Meckel's diverticulum, the true diverticulum that follows the rules of toes. And if the gut fails to return into the abdomen properly, you get an omphallocele. Now let's talk about the support structures that keep your embryo alive before the placenta takes over fully. The primary yolk sac forms around day 8 or 9 and gets replaced by the definitive secondary yolk sac. This yolk sac wall is actually where your patient's future eggs or sperm start out. as primordial germ cells before they migrate to the genital reach in week 4. The yolk sac is the earliest site of the blood cell formation. In these blood islands, weeks 3 through 6, the Allantois is an outpouching into the connecting stalk and it contributes to the bladder. Once development is done, its remnant becomes the urachus, the median umbilical ligament in adults. Here is your clinical pearl. If that urachus stays open, a patent urachus urine can literally leak out through your patient's umbilicus. Two more membranes finish the picture. The amnion lines the amniotic cavity and produces amniotic fluid. The chorion is made of extraembryonic mesoderm plus the cytotrophoblast and syncytiotrophoblast. Its villi forms the fetal side of the placenta. Together they fuse into amniochorionic membrane, what your patient calls her bag of water. On the maternal side, the placenta is built from the decidua basalis on the fetal side from chorion condosum and the placental barrier. From maternal blood to fetal blood goes syncytotrophoblast, then cytotrophoblast, then villous connective tissue, then fetal capillary endothelium. Late in pregnancy, the cytotrophoblast layer thins out, making that barrier even easier to cross. The umbilical cord itself has two umbilical arteries carrying deoxygenated blood away from the fetus, and one umbilical vein carrying oxygenated blood to the fetus. Cushioned in Wharton's jelly, find only one umbilical artery on ultrasound. That's a red flag. It's associated with other congenital anomalies, especially cardiac and renal, and it warrants further workup. Now let's shift gears and talk about what happens when this process splits into two. Dizygotic fraternal twins come from two separate eggs, fertilized by two separate sperm. So they are always diamniotic and dichorionic. And genetically, they are just siblings who happen to share a birthday. Monozygotic identical twins are a different story entirely because they come from a single zygote that splits, and whether they share a placenta or a sac depends entirely on when that split happens. If it splits at 0 to 4 days, while still a morula, you get a diamniotic dichorionic twins, each with their own sac and own placenta. If it splits a bit later, at 4 to 8 days after the blastocyst formed, but before the amnion develops, you get diamniotic more monochorionic twins, separate sacs, shared placenta. Push that split further to 8 to 12 days after the amnion has already formed, and you get monoamniotic monochorionic twins, one sac, one placenta, and the highest risk pattern of the group because the cords can tangle. And if the split happens after day 13, once the primitive stick has already formed, the split is incomplete and you get conjoined twins. It's worth remembering too that any monochorionic twins share placental blood vessel connections, which puts them at risk for twin-twin transfusion syndrome, where one twin gets too much blood flow and the other too little. Now let's talk about the medical risk. Not every week of pregnancy carries the same risk, and this timeline is one of the most testable concepts in embryology. During the first 2 weeks, it's all or none. If a teratogen hits now, either the conceptus survives completely unaffected or it's lost entirely. Cross structural defects are rare at this stage. Weeks 3 through 8 is Organogenesis. This is the period of greatest risk for major structural malformations. This is when limbs, heart, neural tube, everything is being built. From week 9 until birth, organs are mostly just growing and maturing. So teratogens now tend to cause growth restriction or functional problems rather than gross malformations. One exception, the central nervous system stays vulnerable the entire pregnancy. And here is a clinical pearl worth remembering. Your patient's first missed period actually falls right around week 3, exactly when organogenesis is beginning. So by the time she even knows she is pregnant, the most critical window may already be underway. Now let's go through the classic teratogen list. This drug defect case shows up constantly on exam. ACE inhibitors cause fetal renal damage. Alcohol causes fetal alcohol syndrome, the most common preventable cause of intellectual disability. Isotretinoin used for severe acne causes craniofacial and CNS defects. Lithium is linked to Epstein anomaly, a malformed tricuspid valve. Tetracyclines discolor your patient's teeth and inhibit bone growth. That's why we avoid them in pregnancy and young children. Thalidomide is the historic one. Limb defects, especially cocomelia, where the limbs are severely shortened. Valporate and carbamazepine both raises the risk of neural tube defects, tying right back to what we cover in Neurulation. Warfarin causes bone and cartilage defects. Maternal diabetes is linked to caudal regression syndrome and cardiac defects. And methotrexate causes multiple congenital anomalies across systems. If you remember one thing from this list for the exam, remember thalidomide and limb and alcohol and craniofacial features, those get tested the most. Now let's talk about the most important clinical correlations of our video. Two clinical entities you absolutely need to recognize first. An ectopic pregnancy implants outside the uterine pouch, most commonly in the tubal and specifically in the ampulla, and less commonly in implants abdominally, often in the rectouterine pouch, the pouch of Douglas. Watch for the risk factors like endometriosis, pelvic inflammatory disease, tubal surgery, or DES exposure. Your patient presents with abdominal pain, vaginal bleeding, or positive SCG, and classically blood on cleidosynthesis. Now, gestational trophoblastic disease. A complete mole is 46XX, entirely paternal in origin. There is no embryo at all. SCG is very high and it carries about a 20% risk of progressing to cholangiocarcinoma. A partial mole is triploid 69XX9, one maternal set plus two paternal set, and fetal tissue may actually be present. As a quick rule for interrupting SCG, low levels point you toward miscarriage or ectopic pregnancy. High levels point you toward multiple gestation, molar pregnancy, or cholangiocarcinoma. Between the weeks 4 and 7, every embryo, regardless of chromosomal sex, builds the same starting structure. The gonads come from the urogenital ridge, a thickening of intermediate mesoderm, and at this point they are bipotential, identical in both sexes. Remember those primordial germ cells from the yolk sac. In week 4, they migrate in and colonize this ridge. Primary sex pods grow inward from the surface epithelium and receive those germ cells. Two duct systems sits ready and waiting. The mesonephric or Wolffian ducts, which become the male internal duct system, and the paramesonephric or Mullerian ducts, which become the female internal duct system. Every embryo starts with both. The switch is simple. No SRY gene, you get an ovary. With SRY on the Y chromosome, testis determining factors kick in, activating SOX9 and FGF9, and you get a testis. SRY mutations lead to 46XY, complete gonadal degenesis, Schwer syndrome, a female phenotype. Now let's follow each pathway to completion. In the male, SRY triggers testis determining factor which upregulates SOX9. Sertoli cells then secrete Mullerian inhibiting factor MIF, which makes the paramesonephric ducts regress. Leydig cells produce testosterone, which stabilizes the Wolffian ducts into the epididymis, vas deferens, and seminal vesicle. And testosterone gets converted by 5 alpha reductase into DST, which is what actually builds the male external genitalia. Testosterone maintains internal structures. DST builds external ones. Don't mix those up on the exam. In the female with no SRY, WNT4 and RSPO1 drive ovarian development instead. Without MIF, the Mullerian ducts are never told to regress, so they persist and become the fallopian tubes, uterus, cervix, and upper vagina. Estrogen later supports maturation of the tract. High yield fact is that MIF belongs to the TGF beta family, and its absence is exactly why you would see persistent Mullerian structures in conditions like a 46XX male with an SRY translocation. Meiosis is how you go from a diploid cell with 46 chromosome down to a haploid gamete with 23, and it happens in two rounds. Meiosis 1 is called reductional because it's where the chromosome number actually gets cut in half. First, homologous chromosomes pair up, that's synapses, forming a structure called a tetrad. While they are paired, crossing over happens. Segments swap between non-sister chromatids, which is where your genetic diversity comes from. Then disjunction. The homologous pairs separate and each daughter cell get 23 chromosomes, though each one is still duplicated. Meiosis 2 is equational. No synapses, no crossing over this time. The centromeres simply split, sister chromatids separate, and you end up with 4 haploid cells total. And here is the clinically important error. If non-disjunction happens in meiosis 1, both homologs end up in same daughter cell. That's how you get conditions like trisomy 21 or Turner syndrome. If you want the full phase by phase breakdown, prophase 1 runs through liptotin, zygotin where synapses happens, pachytin where crossing over happens, then diplotin and diakinesis. Metaphase 1 lines up the homologous pair. Anaphase 1 separates them, and telophase 1 finishes with two haploid cells. Then prophase 2, no replication this time. Metaphase 2 aligns the chromosomes. Anaphase 2 splits the centromeres, and telophase 2 gives you your final haploid gametes. Spermatogenesis starts at puberty, and unlike what we will see in the next scene, it just keeps going continuously for the rest of a man's life. The whole process takes about 74 days and happens inside the seminiferous tubules. Spermatogonia, which are diploid, proliferate by mitosis into primary spermatocytes still diploid. Those go through meiosis 1 to become secondary spermatocytes, now haploid but still duplicated. Meiosis 2 converts them into spermatids, fully haploid. Spermatids then undergo spermiogenesis, a maturation process, not another division, to become mature spermatozoa. And here is the key contrast between to remember. One primary spermatocyte yields four functional sperm. This whole process is regulated by FSH, LH, and testosterone. Infertility can trace back to defects anywhere in this pathway. Y chromosome microdeletions or Sertoli cells only syndrome are classic causes. Now compare that to oogenesis, which is almost the opposite story. This process starts before your patient is even born. Oogonia enter meiosis 1 and become primary oocytes, but then they arrest in prophase 1. By the time she is born, she already has her entire lifetime supply, roughly 1 to 2 million primary oocytes, sitting frozen in that arrested state. At puberty, each menstrual cycle, a cohort of these primary oocytes finally resumes meiosis 1, and just one completes it to become an ovum. And meiosis 2 does not even finish here. It only completes if and when fertilization actually happens. So while spermatogenesis gives 4 sperm per starting cell, one primary oocytes give just one ovum, plus 2 to 3 polar bodies from unequal cytokinesis. And this is exactly why maternal age matters. Those oocytes have been arrested in prophase 1 for decades, and the longer they sit, the higher the risk of the non-dejection, especially in meiosis 1. Let's lock this comparison in by reading straight across the table. Location. Spermatogenesis happen in the seminiferous tubules. Oogenesis happen in the ovarian follicles. Initiation. Spermatogenesis kicks off at puberty. Oogenesis actually begins back in the embryo, then arrests for years. Continuity. Sperm production is continuous, happening daily. Egg production is cyclic once a month. Gametes per meiosis. One primary spermatocyte gives four functional sperm. One primary oocyte gives just one ovum plus polar bodies. Meiosis 1 completion. In sperm, it's continuous throughout the process. In the oocyte, it only finishes at ovulation. Meiosis 2 completion. Sperm finish meiosis 2 before they are even released. The oocyte does not finish meiosis 2 until after fertilization. And the end products reflect their jobs. Sperm are small and motile, built to travel. The oocyte is large and non-motile, packed with nutrients for the earliest stages of development. This table is the master reference for everything we have talked about so far. Every organ in the body traces back to one of these three columns. Ectoderm gives you the epidermis, hair, nails, sweat glands, the nail lens, and the cornea of the eye, inner ear, tooth enamel, the anterior pituitary from Rathke's pouch, the entire neural tube, that's your brain, spinal cord, retina, and pineal gland, and everything neural crest builds like the adrenal medulla, ganglia, Schwann cells, and melanocytes. Mesoderm builds all three types of muscle, bone, and cartilage, blood, and the whole cardiovascular system. The adrenal cortex, gonads, kidneys, dura mater, the notochord. Remember, that becomes nucleus pulposus and the endocardial cushions and aortopulmonary septum in the heart. And endoderm lines the entire gastrointestinal tract, foregut, midgut, hindgut. The lower respiratory tract, larynx, trachea, and lungs, and the bladder, urethra, and lower vagina, the pharyngeal pouches that become the thyroid, parathyroids, and thymus, plus the liver, pancreas, gallbladder, and the submandibular and sublingual glands. And don't forget the extra embryonic contribution. The yolk sac is where primordial germ cells and the earliest blood cells and vessels comes from. Before we finish, let's fire through the highest impulse from across the whole topic. These are the ones exam love to test in isolation. SRY sits on YP11.3. A translocation of this gene can produce an XX male or if it's lost an XY female. MIF, also called AMH, does not just regress the Mullerian ducts, it also important for the testicular descent. A WNT4 duplication can actually cause a 46XX testicular disorder of sex development. On the gametogenesis side, remember, crossing over happens in prophase 1, but oocytes sit arrested at that exact stage for decades. Non-disjunction in meiosis 1 sends both homologs into the same daughter cell, which is how you get trisomy. And polar bodies from oogenesis are not functional gametes, they simply degenerate. Let's have a quick recap. Fertilization happens in the ampulla with the cortical reaction blocking polyspermy. Implantation happens in the posterior uterine wall around day 6 to 7. And the Trophoblast is what produces the SCG. And the exam nugget worth remembering above all is the first missed menstrual period lines up with the week 3, exactly when organogenesis begins, which is the single most vulnerable window for teratogens in the entire pregnancy. Let's zoom all the way out and put out the entire pregnancy on one timeline. Week 1, fertilization, cleavage, the morula, the blastocyst, and implantation. Week 2, the bilaminar disc forms along with the amniotic cavity, yolk sac, and core ionic cavity. Week 3, gastrulation, the primitive streak, the notochord, and the neural plate. Week 4 through week 8, this is organogenesis. Folding happens, neurulation happens, the heart starts beating, the neural tube closes, limb buds appear. This is the period of greatest teratogenic risk in the entire pregnancy. From week 9 to the end of the first trimester, your embryo officially becomes a fetus, and external genitalia becomes to differentiate with rapid growth in length. In the second trimester, weeks 13 to 27, organs mature and grow. Your patients start to feel quickening. Fetal movement and viability is approached late in this window. And in the third trimester, from week 28 to birth, the fetus gains weight rapidly. It starts producing pulmonary surfactant and the CNS keeps maturing right up until the delivery. From one cell to a newborn, that's the entire journey. One zygote, 3 germ layers, 2 gonad pathways, 9 months, 1 human being. That's the embryology. Memorize the timeline, know your teratogens, and the rest falls into place. Thanks for watching.